I am now pleased to introduce Dr. Amol Navathe. Dr. Navathe is an assistant professor of health policy and medicine at the Perelman School of Medicine at the University of Pennsylvania. He is a commissioner of the Medicare Payment Advisory Commission, or MedPAC, a nonpartisan agency that advises the U.S. Congress on Medicare policy. He's a leading scholar on payment model design and evaluation, and we're so honored to have him with us today. Amol?
Hello, everyone. Welcome to the session today. First off, Catherine and Nancy and the NIHCM Foundation, thank you so much for inviting me today. Fantastic. So what we're really going to be focusing on today is the role of physicians in accelerating value-based care and adoption, and most importantly, the implementation and how to succeed. So if we can go to the next slide, please. This has been an exciting time. Obviously, the pandemic has been a challenging time. But if we reflect upon the past decade, some of the statistics that Catherine noted, that we've had some adoption, but there's been an increasing acceleration in adoption. And one thing that's really important to understand is that physician groups, in many ways, are in fact leading the way in value-based care. So what do I mean by that? First, physicians have been driving a lot of the adoption. Physician groups in particular have been driving the adoption and participation in various programs. This is from public health plans and private health plans alike. If we look at the map on the right side here, this shows us a map of the United States where we're looking at the penetration of ACOs. This is specifically in the Medicare program across the United States. Darker means more adoption, lighter means less adoption. What we can see is that by 2021, we have fairly widespread adoption that's certainly geographic in some areas where it's of greater concentration, but nonetheless, this is a national view. If I showed you this from 5 years ago to 3 years ago to today, you would see a steady darkening of this slide, meaning that ACO adoption and participation is increasing in a continuous fashion. Now, one thing that's really important to note is that in many respects, physician groups have actually outperformed other types of entities, such as hospitals, in leading ACO participation and outcomes. So work by colleagues such as Michael McWilliams and Michael Chernew and others has shown us that the results within Medicare ACO programs, for example, have been stronger. This means higher results or better results on quality scores, more cost savings. Physician groups have actually been a linchpin of this progress. Not just in ACO programs, it turns out. Even if we look at bundle payment programs, physician participation has grown rapidly. And in fact, in today's current BPCI advanced programs, for many types of medical episodes or surgical episodes, it is in fact physician groups that are driving more of the participation than other entities like hospitals or post-acute care facilities. Once again, physician groups are driving the way. Now, this is obviously not happening in a vacuum. There are other policy dynamics at play. The Merit Incentive Payment System, or MIPS, has created multiple tracks that I think in a lot of ways, due in part to complexity and due in part to uncertainty around the way that penalties may be implemented, has served as an impetus to participate more in alternative payment models and value-based payment models. Why? Because it's a way to guarantee or step out of the uncertainty and create some certainty around the types of bonuses that one might gain. Now, in parallel to the Medicare statistics and dynamics that I'm highlighting, commercial payers have also been driving tremendous amounts of transformation in terms of physician groups participating in value-based care. Just to mention a few, Horizon Blue Cross Blue Shield in New Jersey, in the New Jersey area, Hawaii Medical Services Association in Hawaii, Blue Cross Blue Shield of North Carolina is another group that in fact I've had the pleasure of working with. These are just a sampling of plans that have been partnering with physician groups. Now, this partnership has existed for many years. What we're seeing is increased investment over time, increased partnership together with physician groups to really propel forward innovative delivery models that are ultimately centered around the patient, not centered around the physician group or the health plan in any way. Next slide, please. So what does this mean? What are the best practices? We are now more than a decade into this, and my research group and others have been studying exactly what successful practices, successful physician groups, successful large networks have been doing together in partnership, oftentimes with health plans. So first, we see best practices around using techniques to support physicians with information, infrastructure, and incentives. This has been wildly successful as a strategy, and there's a whole industry now of enabling types of companies that work together with physicians and health plans to make this become a reality. What are the tactics that they take on? They take on several tactics, many of which have common themes. First, they use rewards in targeted ways around short-term performance indicators, not relying just on the shared savings that may come 12 or 14 or 16 months after the performance year has started. They provide estimates, tangible, specific estimates of incremental revenue that practices would not receive if they didn't meet the targets. They provide comparative data. This is critical. There's actually a ton of policy evidence now that comparative data is a way to drive physicians and physician groups to change the way they practice, oftentimes within the same ACO. So comparing physician group A versus physician group B, all of which under the same umbrella of the same ACO. Encouraging, oftentimes supporting directly through coaching interventions or otherwise, physician groups to focus on key upstream key performance indicators or KPIs. There's been an emphasis on prioritizing high-risk patients and others specifically to try to close gaps. And wherever possible, create automated work lists or work plans. Make this job easier. Let's make the path of least resistance the correct path for patients. Side by side to this, we've seen investments in the culture of physician-led care. And this has been fantastic. I think it's a really important development to think about not just achieving the triple aim, but also the quadruple aim, where we put the physician well-being, the lack of physician burnout as another centerpiece in our goals around value-based care. So here, transparency, co-creation, getting buy-in, engaging clinicians early in the process to do things like selecting appropriate measures, excluding ones that may not be that appropriate, and defining salient incentives. These are, again, some of the important steps forward in engaging physicians early, but also defining a culture that is physician-led or clinician-led in some way. Just a couple of others to quickly mention. Enabling development of workflows and other tools to support clinicians in improving their clinical practice patterns. Engaging early to understand what are some of the potential unintended effects that might happen here. What are ways in which we as an administrative leadership may not understand what's happening on the ground at the patient point of care level? And these are all in support, again, of creating a culture of change, because guess what? Change is hard. We have decades and decades of research to tell us that, but I think most of us would say we know that change is hard. Next slide, please. This is obviously, again, not happening in a vacuum, particularly given the current times that we're living in with the COVID pandemic that seemed in some sense like it might be abating and then has created a bit of a resurgence recently. But while we've had some drawbacks, obviously, or some challenges that have been devastating under COVID, there's also been some silver linings for healthcare, some unlocking of potential. I think one of the chief ones here is telehealth or digital health. This is a really interesting case example in some sense, where the technology for digital health and telemedicine has existed for years and years and years, as Zeke Emanuel and I actually outlined in the New York Times op-ed. And yet what we found is when there was an impetus for change, a reason to overcome this inertia, the healthcare community and provider community at large, embraced telehealth and adopted it incredibly rapidly. This has unlocked a whole bunch of opportunities for how to care for patients in their home, do infusions in the home that may be actually safer even when you don't have a pandemic than doing them in the hospital setting, increasing hospital at home care. There's a variety of new ways in which we can deliver care that will require the partnership of health plans and physicians. And I think one of the interesting pieces here is as health plans, health systems, and physician groups work together to drive this forward, there's an increasing recognition that the majority of care and tons of innovation that we're seeing is happening driven outside in the outpatient setting. Now, this may be in an outpatient facility, an outpatient hospital, or in an ambulatory surgery center. But the point being that physicians are playing a central role in driving this change, whether in the hospital, out of the hospital, or at the nexus, where we're starting to see more and more advanced care. The last thing I'll highlight here is over the past several years, we have seen that the average risk, the severity of patients who are managed outside the hospital is getting higher and higher. Patients are getting sicker and sicker, and the capability of hospitals to take care of sick patients is only ever increasing. But that also means that the margin of patient, the type of patient who ends up being cared by clinicians and organizations in the outpatient setting is also increasing. This is, again, where we need collaboration across the multiple entities together to drive the right type of innovation. And that in itself has to be physician-led in part. So why don't I close here, and I look forward to a great panel. Thank you.